Hi, welcome everyone to today's PHSSR Research and Progress series. Our kind of general topic is bridging health and healthcare. Today's presentation is titled Local Public Health Clinic Retraction and Reproductive Health Services Utilization and Outcomes. Our presenter is Nathan Hale, PhD. Nathan's Research Assistant Professor in the Department of Health Services Policy and Management at the University of South Carolina Arnold School of Public Health. Nathan also serves as the Deputy Director of the South Carolina Rural Health Research Center. Nathan is a PHSSR researcher with funded projects examining things ranging from the shifting role of local health departments as clinical service providers on service receipt and outcomes among rural and vulnerable populations to areas such as the health and well-being of women and children. Prior to his current role, Nathan worked in public health practice at the local, regional, and state level in multiple states, which really largely informs his research. So Nathan, let's start.
All right. Well, thank you, Rick, for the kind introduction, and thank you to those who have taken time out of your busy days to call in. I certainly appreciate it. So today we're kind of talking about some of the things that we've learned in South Carolina, particularly when local health departments actually retract clinical services. And in this context, we're talking about specifically for reproductive health and family planning. But before we kind of get into some of the details here, I would kind of like to take a minute and just kind of put this research in some larger context to kind of help frame it up a little bit. So, at its core, public health has always been about providing population-based public health services. We all kind of understand that. But I think that there's also this, we also tend to oscillate a little bit back and forth between the exact role of local health departments as a clinical service provider. And, historically, deficiencies in some of the primary care systems that we see, particularly in rural and underserved communities and particularly for women and children, local health departments have tended to kind of fill a gap in many of these communities over time. I think more recently the pendulum has kind of swung back in the other direction, and with the IOM reports and recommendations coming out, accreditation, even healthcare reform, there's lots of emphasis and focus being placed on kind of shifting back to this population-based model. At least in my mind, one of the questions that's still kind of hanging out there is what do you do with the local health departments who are kind of entrenched in this clinical service provision model? I think that there's a lot that we can kind of learn, as local health departments make this transition. I think, we need to understand, if the wheels fall off the wagon, if communities are able to adjust, and if that's the same across different communities, and so on. So I think that there are some bigger, contexts in which this research, kind of sits. And it's kind of in this vein that we're going to talk about the research we have done in South Carolina today. So moving forward, just kind of restating a little bit, but I think we all would agree that population-based health is kind of the way that we are moving. That's what we want. That's ideal. But the reality is that there are lots of health departments who are still kind of entrenched in this clinical service provision model. For example, up to half of the local health departments are still engaged in family planning. A good number still do immunizations and things like EPSD&T services for children. 35 to 45% of health departments still provide these types of services. So they're still very actively involved in providing clinical services. And I think when you start talking about things like the economic recession and healthcare reform, it kind of gets even more complicated. I think that there are some questions about whether or not the economic recession will actually drive local health departments further into the clinical service provision model. And even things like healthcare reform, where we see, it could be a very good catalyst for reexamining priorities and discontinuing clinical services. But, we also see that just, in some of our other research, that just because you have insurance doesn't necessarily mean that you're going to have improved access. So I think that this whole idea of, clinical service division and local health departments is still somewhat of a fluid topic. But regardless of kind of how we frame it up, the reality remains that these transitions are occurring more frequently, and there's some things that we can learn as those transitions occur to kind of help us moving forward. So as these transitions occur, at least in my mind, there are really two, kind of critical questions that we need to examine. One being what happens when the transition is made. So what kind of impact, does the transition have on the services that were being provided and longer-term outcomes as well? So when you discontinue providing clinical services, does that really translate into, a demonstrable impact on population-based health outcomes? But I think the second piece of this is, how do you mitigate the potential impact? So when the decisions are made, to kind of pull back from this service model, how do you alleviate some of those problems that may arise as you do so? So this is actually what we had the opportunity to examine in South Carolina, and it's the focus of the research that we've done here. So just to give you a little bit of background to kind of frame this up. So, South Carolina is a centralized public health system, so it's a little bit different maybe than some of the other local health departments around. But when we're talking about the state public health agency, you'll hear me refer to them as DHEC. So that's kind of the shorthand for the state Department of Public Health. So DHEC is the provider for Title X services, which are clinical services for family planning. So across the state, these services are delivered in local health departments, in all 46 counties that we have. And in some counties, there are multiple clinic sites that deliver these services. So kind of within this context of family planning in South Carolina, about half of the caseload that we see in our family planning clinics are from women who are enrolled in Medicaid. So we're definitely a significant provider of family planning services for those who are enrolled in Medicaid. Well, what we've seen, over the past 10, 15 years or so, the state itself experienced some pretty significant fiscal constraints, like a lot of states did. And particularly for us, there was a tremendous drop in revenue from state and local resources simply to fund family planning. So what we ended up seeing in South Carolina was that as these, fiscal constraints, really kind of started to take home, we started to see a shift in how the local health departments dealt with it. But just to give you some perspective on what we're talking about here. So this particular figure gives us the total revenue that the state was pulling in related to family planning, and you can see clearly that in 2004 there were significant drops, and there are reasons why this happened that are kind of beyond the scope of this talk. But clearly you're talking about a 35-40% decrease in the revenue that you were used to having. So it shouldn't be a surprise that as we saw that decrease in revenue, we also saw a decrease in family planning caseload, somewhere to the tune of 28, 30,000 or so women over the course of a 10-year period. So what ended up happening with all this was, because of the fiscal constraints and because of all the things that were going on within the state, the local health department started to retract a lot of their clinical services, particularly for family planning. I think it's important to point out that this retraction of clinical services kind of took a couple different forms. For some local health departments, they just reduced staffing and clinic hours, so it was more of a reduction in capacity. But there were a few local health departments, particularly that had satellite clinics, that just flat out closed their clinics. So you kind of have both of those going on. And from a research perspective, this is really nice, and it created a national experiment for us to look at. And then we also had a lot of geographic variation. So this reduced capacity was pretty much distributed across the state. And when we saw clinic closings, those were distributed across the state as well. So it wasn't all isolated to a single area. So there was lots of geographic representation involved there. And we also saw a lot of time variation in the sense that, some of these, capacity reductions and clinic closings happened, as early as 2003, 2004, kind of running all the way up through 2010, with the majority of them kind of happening, slightly prior to the recession. So I think the key point that I would like to take from this is that, over time, this didn't just happen overnight. So it was, somewhat of a gradual process that makes it very conducive for research and looking at it in the context of what we're examining it on. So we really kind of had two specific aims with this project that we were looking at. And one is to look at the impact of this service retraction on the receipt of annual family planning visits, which is pretty straightforward to some degree. But we also kind of wanted to try and move it out a little bit and also examine whether or not this retraction had some type of impact on population-based health outcomes to the best that we can derive those from the data that we had. So those are kind of two overarching aims of the project here. So kind of getting into some of the more specifics here, talking about our data. So we pulled a cohort of women enrolled in Medicaid going back to 2001 and following them through 2012. So we used Medicaid eligibility and billing data to derive this cohort. So we treated it like a rolling panel, so starting in 2001, running through 2012. And we started the clock on the women who were enrolled the first year that they were eligible. So the year that you were eligible on record, we started keeping up with you in our cohort and just followed these women over time to see what happened to them as far as whether or not they received annual visits and any the subsequent outcomes that we were looking at, how those things unfolded. So a little bit more specifically, we looked at whether or not women had an annual visit, which I've already mentioned. The two outcomes that we focused on were ones that we thought were more proximal to what would happen if there was a service disruption. And the two that we kind of focused in on were whether or not women ended up with a sexually transmitted infection. And the second one that we focused in on was short pregnancy spacing. So if you had another pregnancy within 18 months of the previous live birth. So we felt like that those were two outcomes that are reasonably associated with something that you might see adversely if service disruption occurred across the state. So we coded all these variables to be dichotomous for each year that you were in the study. So for each year that you were eligible, we basically said, did you have any of these, yes or no? And then track these things over time. So obviously time, we wanted to see how these things change. So time is very much one of our independent variables that we were focused in on. Another thing that we realized when we kind of got into this study, we ended up creating a county topology, if you will, kind of a four-level categorical variable to kind of characterize what we were seeing go on across the state. Now I kind of put my hands above the table here and say that this is not necessarily the original intent of how we wanted to go about looking at the data. Originally, we were just going to focus in on whether or not women who were being seen in the clinic that closed, kind of what happened to them over time. But what we quickly realized when we got some of the data that we were looking at was that clinic closings are really kind of the tip of the iceberg. So in a lot of cases, what ended up happening was, you may have a large county that closed a satellite clinic that may have had a volume of, 100, 150. But in their big clinic in the county, they may have been seeing, 6,000, 7,000 women or so, but they were reducing capacity in a significant way through, reduced hours, reduced staffing, that kind of thing. And the actual impact that we saw as far as the sheer number of women affected was actually a lot higher in these counties that reduced capacity, in a lot of cases more so than when they closed the clinic. So we felt like our original approach really wasn't capturing the true essence of what was going on. So we ended up coming up with this kind of, to this topology to kind of get at the characteristics of the counties that we observed. So we had our counties that were just kind of humming along, and, they really didn't reduce capacity that much or experience reduced capacity. They didn't close the clinic. So these are kind of our reference group, if you will. Our second group of folks that we were interested in were those who, reduced capacity in a significant way, but didn't close the clinic. The third group that we were looking at were those who reduced capacity but also closed the clinic. So that one's kind of the one that we were the most interested in, where you've got significant capacity reductions and clinic closings. That would probably be the less than ideal scenario. And our fourth group is, the group that, they experienced no reduced capacity, but they did close the clinic. So I think that we might consider this group kind of our positive deviants, if you will, those who were able to kind of close it, but not really experience reduced capacity. So these are the ones who did a good job of shifting these women to other sources of care in all likelihood. So admittedly, we were trying to figure out how to characterize reduced capacity, and there seemed to be kind of natural breaks in our data. But we looked at the state reduction in the caseload over time, and it was about 30% if you look between 2001 and 2012. So we just kind of used that as an anchor point and said that, if you had, reductions in your caseload capacity that were over what the state average was during the time, then we were going to consider you, to kind of have excessive reduced capacity. So we just kind of used that somewhat arbitrarily as a cut point to classify our counties into this topology. So thinking about the analysis, and again, we because this was panel data and we had repeated observations on women over time, we used generalized estimating equations. For those of you who are familiar with these things, they're pretty common for analyzing correlated data. Probably the important thing to point out here is that these particular models give you population average probabilities or marginal means. So at least in this regard, we were because of the way the data was structured, we felt like it was a little bit more conservative for us to derive these population average probabilities that, given the data, that was probably the safest bet for us. So that's what we ended up going with to look at these average probabilities over time. So what we were particularly interested in was the interaction of time with our county topology. So, given the characteristics of the county that we saw over time, what happened in these particular communities. So you can see the specifications of the models that we ran. So I'm a data user, so we use the XTGE commands, with binary data. We use a logit link with an auto-regressive correlation matrix with a single lag. So if that makes sense to you, then hopefully that'll make you happy. One thing that we also did was looked at the marginal effect. Stata has these nifty commands that allow you to kind of look at the marginal effects and really visualize these population average probabilities. So that's kind of the approach that we took with trying to figure out what happened with the outcomes that we were looking at over time in these particular counties. So kind of get into some of the results that we found, at least descriptively. If you look across our topologies, I think the important thing to point out here is that we had, fairly good representation as far as the study population is concerned across all 4 groups that we were looking at. So we'd probably be more concerned if there was a topology that didn't have a lot of individuals in it. But overall, our topology 3, which is our reduced capacity and a clinic closing, was by far, had a little bit higher proportion. But there's representation across all the topologies. So this is something that I want to point out, and I'd like for you to kind of keep in mind as we go through the rest of the results. So what you're looking at is the number of newly enrolled Medicaid eligible women by county topology in years. So basically what this is showing you is that the number of newly enrolled Medicaid women, and what I would like to point out is that starting in 2007 and 2008, regardless of the topology that we're looking at, we see a pretty substantial upswing in the number of newly eligible Medicaid women. So, at least in our mind, in 2008 was kind of the beginning of the recession. So, kind of following the recession, we see that the number of newly eligible women increased. So, in our mind, that would kind of represent an increased demand for a lot of these counties as we move forward. And one thing I would also like to point out is that there was an upswing across all of our topologies, so it wasn't specific to one. So there was proportional, increases across the board. So as we kind of move on through the findings and the results, just kind of keep that in mind. So just, purely from a descriptive bivariate, just kind of looking at everything that we have. If we look across topology, you can see that on average about, 1 in 4 women, 25% or so, had an annual visit in a given year. And that's fairly consistent with some of the other numbers that we've seen across the state, so that made us feel a little bit better. But again, interesting, this is, not bound by time. This is just kind of looking across the entire duration of the study. We see some bivariate differences, but they're not overwhelming. The proportion of women with the highest rate of annual visits were in topology 3, which is the one that we're the most concerned about, the ones that reduce capacity and close the clinic. So, again, just kind of pointing out that, we see some differences, but they're not, they're not overwhelming necessarily. So getting to some of the more specifics here. So when we started running these models, again, we use these, generalized estimating equation models and look at these population average probabilities. Just a couple of things to point out. You can see at the bottom of the table, you can see all the different variables that we also include in the model. So I'm only showing you kind of the ones we were interested in, but we tried to account for as many other factors as we could, get at with the data that could also explain what we're observing here. So just, this table without everything else are, marginally helpful. But the thing that I want to point out is that the interactions between topology and year are significant for annual visits. And if you kind of look at the main effect variable there, and then with the interaction, you can see that in some cases the coefficients kind of flip. So that is something that would give us a little bit of concern as we move forward. So it's probably a little bit better to, kind of visualize these things. So when we use the margins command to look at these average probabilities over time, this is what we see going on as it relates to annual visits. So a couple of things to point out here. You'll see that the gray line, the gray line and there's another black line in the middle, but you can see that there are two of our typology counties where you see an actual increase in average probabilities over time. And that is our reference county, and those are our positive deviants who appear to have increases in average probabilities over time. The two that are kind of sitting there flat are the counties that reduced capacity that didn't have a clinic closing, and the counties that reduced capacity that did have a clinic closing. So that in and of itself we found to be pretty compelling in that, if you look at the arrow there around 2008, when we kind of think about the recession, we think about what we were observing with our data, it kind of struck us that it wasn't so much that the counties that experienced these significant reductions in capacity in closed clinics, it wasn't so much that they lost a lot of ground when they did that necessarily, but whenever the demand tended to increase in 2008, it appears as though they weren't quite as fluid to respond to that increased demand. So, it's, again, these are, based off the data, I mean, we're somewhat limited to what we can say about it, but that kind of struck us as what's probably going on here. So we kind of look at these, just looking at the marginal effects. If you're, comparing the average probability to the reference population to the other groups, and we can see a clear, delineation here that are the two counties that we're the most worried about, the ones that reduced their capacities with and without a clinic closing. We see that they did tend to lose ground over time relative to, our reference population. Kind of moving along, we also see kind of similar findings to some degree with the outcomes we were looking at. So when we looked at sexually transmitted infections, again, just kind of pointing out in this table that the interaction was significant. So we do see at least some evidence that, these things kind of vary by typology over time. And interestingly, when we kind of look at the output from these models, we see that there's, the trajectory in our reduced capacity counties that close the clinic is a little bit steeper than what we observed in the other counties, but, relatively speaking, they're all kind of tracking in the same direction, so they're increasing across the board. So, there may be something going on there, but it wasn't particularly compelling when we started to look at it. And again, I'll, kind of point out that the effect sizes are pretty small here, so we're not talking about huge differences, so it's just something to keep in mind as well. Again, so when we look at the marginal effects, it's, you can kind of see a similar trend going on there. There does appear to be a stronger marginal effect in our counties that have reduced capacity and a clinic closing relative to other counties, but again, the coefficients that we're kind of dealing with here are pretty small. We see similar outcomes when we start talking about repeat pregnancy. So probably not as strong of an effect size going on here with the coefficients, but again, all the outcomes that we looked at across the typology, they all tended to kind of track in the same direction. So there was a little bit of variation perhaps in the effect, but they were all kind of moving across the same plane, moving across the same trajectory. So we thought that it was interesting, and there may be some things going on there, but all in all, it didn't seem to be particularly compelling, if you will. So those are, again, and those are just the marginal effects, kind of visualized a little bit different. So that's kind of what we found in this particular project. And I think that if we're kind of summing it up or discussing it a little bit, I think what we would be comfortable saying is that, the reduced capacity, the retracting of the clinics, whether it was included a clinic closing or not, that reducing capacity, certainly created some level of disruption, within these counties. But I think that we would make the case that the disruption in this context is really more in the sense of being able to respond to demand. So it doesn't appear that they necessarily lost a lot of ground. They appear to perhaps have been able to kind of maintain what they were doing before, but when demand increased, they just don't really appear to be able to keep up with it. And I also want to point out that, even, the largest difference between our typology counties is about 6% in the average probabilities over time. So we're not talking about, even though I'm saying that there's, some differences in the counties, the effect sizes are pretty small. So we don't want to, kind of overstate the impact that we observed. When it relates to the outcomes that we looked at, we do see that the marginal effects are somewhat stronger in counties that reduce capacity. But again, the magnitude of these effects are pretty small. The coefficient sizes are pretty small. So, given the fact that the trajectories among the typologies, kind of track in similar ways, we found it to be interesting but not overly compelling. So, like, we don't really see a ton of stuff going on here necessarily. So kind of thinking about this, kind of how this fits into public health services systems research. I mean, I think that, the implications, kind of occur on three levels, and particularly for the individuals. I think that anytime that you reduce capacity or close a clinic, that's going to create a burden. It's going to create a burden on the women who are receiving services at the health departments. They're going to have to find other providers or find alternative means of getting those services. In a lot of ways, that's a burdensome task. But for those who are kind of, living and trying to do this in a rural or underserved area, that could be even more burdensome for a lot of women. If you talk to a lot of our family planning folks at the state health department, they'll make the argument that the quality of services that they get at the health department may be a little bit different than the quality services they get in the private sector. That may or may not be true, but I definitely think that there are a lot of additional screenings and other services and benefits that kind of come with family planning that's delivered through the health departments that may or may not be available to women who have to seek care in other places. And I think at the end of the day, the reality of trying to find services for women really shouldn't be dismissed. I mean, it's an important thing to consider at the local level and at the state level as well. Kind of moving the implications up to the state level a little bit. Anytime that you have funding decreases, whatever they look like, they're going to be trade-offs. And, you're going to have to make tough decisions about what you're going to provide and what you're not going to provide. But in any event, whenever you make these types of transitions, particularly as it relates to clinical services and local health departments, the assurance role becomes critically important. The local health departments really, I think the onus is on them to make sure that when they make these transitions that they're really playing an active assurance role. And I think that's particularly compelling in our study because, we found that, whenever these counties reduced capacity but didn't close a clinic, we found that was equally as disruptive as closing a clinic. So I think there might be some complacency involved that if you're just reducing a clinic and you're not closing it, you may get a little complacent about how you case manage these women or how you assume that assurance role. And I think one of the take-home messages from what we found here is that, even if you're reducing capacity, even if it doesn't include closing a clinic, you might want to be equally as rigorous in those assurance efforts when you're doing those types of things, even as you are when you're closing a clinic. So kind of thinking about this, even in the more broad sense nationally, I think that whenever whenever health departments discontinue providing clinical services, that's going to have an impact. I think it would be very naive to assume otherwise. I think the real question is probably more what is a tolerable impact? And I don't know that there's really an answer to that question. I think, at least in our study, we saw some disruption, but we really didn't see any, changes in outcomes that would, that would really kind of raise our eyebrows and think, oh, that's really bad. So I think that it's, I think that's something that's open for discussion is exactly what kind of impact is tolerable and if it's the same across different communities. And also, if you kind of think about the implications in the context of the Affordable Care Act and the recession, I think it's likely that, local health departments who are doing or who are providing clinical services, I think that it's very likely that they may face increasing demand. And I think I think it might be very difficult for lots of local health departments to make this transition entirely. So it may be unrealistic to say, everybody just stop doing family planning or providing clinical services. We kind of feel like this targeted retraction, similar to what we saw in South Carolina, is probably the more likely scenario. So it may be that, you're starting to pull back your capacity, to some degree, but you may have to leave capacity in other areas that may go unserved otherwise. So I think at least in the context of that, our study is, kind of helpful in that we see that it's not kind of an all in or all out scenario, we see some more targeted retraction going on, and we see that the impact is somewhat marginal. I mean, there's an impact, but it's relatively small. But I also think that there are increasing opportunities in that with a lot of the reforms that are coming out and the expansion of FQHCs and the medical home initiatives and the other funding that may be available for more population-based health activities. If there was a time for local health departments to consider, retracting clinical services, now might be the time to do that, because you've got an increased focus and other things going on that may help you mitigate that impact. So I think with that, that's kind of all I have lined up to talk about today. So I guess I will kick it back to the moderator if someone has a question for me, or if we need to move it to someone else now.
Nathan, thanks so much for that interesting and timely presentation. We have two folks to comment on today's presentation. The first is Alana Knutson. Alana Knutson, she's a principal research scientist and the co-director of the Walsh Center for Rural Health Analysis at NORC at the University of Chicago. She's also the deputy director for the Rural Health Reform Policy Research Center. She has 20 years of experience leading health services and health policy research projects and implementing and evaluating the impact of public health programs. The majority of her current research and evaluation projects are targeted at providing policymakers with baseline information to inform decisions pertaining to healthcare reform investments, and public health and healthcare reimbursement. Prior to joining NORC, she worked on state and national public health research and policy with an emphasis in the areas of rural health and informatics. Our other commenter on today's presentation is Michael Smith. Mike is the maternal and child health epidemiologist and director of the Division of Research and Planning in the Bureau of Maternal and Child Health at the South Carolina Department of Health and Environmental Control. He's worked for the State Health Department for the past 8 years and has worked in the Bureau of MCH for the past 5 years. During this time, he's been involved in many aspects of public health surveillance, data preparation and analysis, evaluation, and using research results to inform policy development. So, Alana, would you like to start?
Certainly. Thank you so very much, and thank you, Dr. Hale, for that very insightful presentation. I just want to take you back to the future in public health, and 15 years ago we were conducting a number of different workshops and seminars across the country discussing the role of core functions and looking at how public health may be evolving away from clinical services. So it's interesting that we continue this discussion even 15 years later, recognizing that public health is unique to the local and state environment in which it is being delivered. One of the comments I wanted to note about was the issue regarding federal funding. A study conducted by Mike Meat for the Assistant Secretary for Planning and Evaluation looked at some of the financing issues over the past several years, and as South Carolina has experienced across the country, we are looking at continued decreased support from state and local for different public health programs. And we're looking at a greater and greater reliance upon federal funding, when in reality some of these programs, such as Title X, may be reevaluated in light of healthcare reforms. And clearly there's an expectation that more clinical services are going to be covered under health insurance, which may move some of the populations that are currently being served in these programs to health insurance. But I just want to point out two important issues that I think are worth noting. First of all, health insurance does not equate with access, and for those of us who do rural research, this is particularly true. You may have health insurance, but if there's not a provider in the community, that health insurance does not help you gain access to clinical preventive services. Likewise, we are also looking at an environment in which a lot of the increase in coverage has come under Medicaid expansion, and two issues are part and parcel to that expansion. First of all, not every state expanded, and I know the state of South Carolina, for example, has not expanded Medicaid services. And when you look at expectations from the federal level that more people have access because they have health insurance in a state such as South Carolina, that is not necessarily the case. Likewise, we may not have providers who have the capacity to be able to absorb the excess number of people who now have health insurance in other states that have decided to expand their Medicaid coverage. So again, an expectation that health insurance expansion is going to increase coverage for all people is something that we need to really consider, and also consider when we're looking at funding these particular programs at the national level. These programs are certainly important, particularly in the states in which public health is the primary provider of these services. Dr. Hale also pointed out another interesting component of this study, and that is that South Carolina is a centralized state, and the governance structure of the public health system for the state may also have an impact. So for example, states that have a centralized public health system are also often states that are more likely to provide clinical services and may be more disproportionately impacted if there are shifts at the national level, for example, for some of these programs that fund clinical services. So we need to make sure that we are mindful from a policy perspective of these potential implications. Lastly, I would like to comment on the importance of outreach that many of these public health clinical programs also have. Many of the state and local public health departments, in addition to providing, for example, the clinical services, also have a large role in outreach to reach some of these populations that may be more difficult to reach from the traditional healthcare providers in the community. So again, being mindful of the importance of funding and ensuring that public health is adequately funded to be able to have sufficient resources to conduct their assurance role is going to be incredibly important going forward. And in summary, I would just like to also commend Dr. Hale on his research, and also be very mindful of the importance of continually conducting this kind of research to see how shifts in the delivery of clinical services or the retraction of clinical services on the public health delivery side impact outcomes for the population that we are serving. Thank you.
Thank you. Do you have any response to that, Nathan?
No, I would just say that that was an excellent summary of some of the issues that are certainly relevant that we need to pay attention to. So thank you for providing those comments.
Great. Let's go to Mike Smith. Mike, do you have anything to add?
Yes. First of all, thank you, Dr. Hale and Dr. Knudsen, for an excellent presentation and some excellent, very poignant comments. I would like to start with a quick disclaimer. I was involved in this research since the beginning. Dr. Hale and I have been working together on this for a while, so I am close to it. But I've also spent a lot of time thinking about it from the state health department side of things, and the agency that has made these decisions and is being evaluated with this research. So I'd like to quickly give a little bit of an additional background, and then talk about the results that are most important to us, and some of the practice implications of those results. And then I'll wrap it up. I'll try not to take too long. So a little bit of additional background about the funding reduction that we saw for family planning in South Carolina. The big drop was due to a state budget cut followed by a state Medicaid payment reduction. The federal Title X funding has been the most stable source of funding that we've had. The first little drop in the funding figure that Nathan showed was the state legislature saying we're giving you money for family planning services, and you're also being reimbursed by Medicaid for these services. So we're not going to give you as much money anymore. And then the second drop was Medicaid, the state Medicaid program, saying that in these family planning visits, we're reimbursing you for the clinical services and for the educational services that you're providing, and we just can't continue to reimburse you for both of those services, clinic and education. So we're only going to reimburse the clinical services. So together, those produce quite a sizable decrease in revenue for the family planning program in South Carolina. And then after that reduction, the brunt of the recession hit. And because of those reductions, the family planning program was spared some additional cuts during the recession. So when those funding reductions came down to the agency, at the time there were 8 public health regions in the state. Those have since been consolidated into 4 public health regions. But at that time there were 8 regional public health directors, and each health director was allowed to absorb that reduced funding in whatever way he or she saw best fit for their population. So that resulted in some counties having no reduction in services because they found another way to make up that lost revenue, and some counties having clinics that closed, and some counties having clinics where they reduced services, so they reduced the number of hours that the clinic was open, or they reduced the number of days a week that the clinic was open, or they reduced the number of clinical staff available to provide services in those clinics. And then there were some counties that had both clinic closings and reduced capacity. So, a closing and reduced hours, or reduced staff, or reduced days. So the result that is most pertinent to us is looking at the utilization of the annual family planning visit. And what we see is in counties with a closing and a reduced capacity, those counties had a very difficult time responding to the increase in demand and the increase in individuals that were eligible for Medicaid as the recession increased the number of folks that were eligible for Medicaid. So reduced capacity coupled with a closing was a really big restriction in being able to respond. And then having just reduced capacity was not almost as big a restriction, but it had the same trajectory. It was also very limiting. And the biggest implication for us that we're taking from this is we really have to be very intentional and very proactive about fighting a false sense of security that may come with just limiting services without a closure. When we close a clinic, the finality of that is very real to the people that work in that clinic and the people that are making decisions at the state level, and it's easier to provide a lot of case management and a lot of care coordination services, which is really that assurance key function in public health, to assure a smooth transition to care in another facility. But we might not have that same sense of urgency when we're just restricting the number of hours or the number of staff or the number of days a week that it's open. So really what we're seeing here is that any disruption in services is a disruption in access. And we have to have our eyes open about that as we move forward. And in any event where we're having to reduce services, either in response to budget constraints or response to shifting focus of public health, moving from direct clinical services to population-based public health services. An analogy that I use when I think about this and talk about this is a library in a large downtown area. So if a library stays open but sells the land that its parking lot is built on, and a gas station is built where the parking lot used to be, even though the library hasn't changed their hours, hasn't changed their services, hasn't really changed anything, it's naive to assume that folks have the same access to the library that they have when there's an easy parking venue very close by. So very similarly, when we make it more difficult to get into a clinic, even if it's still open, we have to be very conscious of that limitation that we're providing, especially in the environment of the Affordable Care Act. It's easy to make the assumption that we perhaps should not reasonably make that people will still have access to these services. And so that's kind of a first blush implication. That's really how we should perhaps respond to this. But another point of the research is, well, why do we see a stronger relationship among reduced capacity, counties with a reduced capacity, than we do among counties with a clinic closing? Is it because, as I just kind of alluded to, that we do better case management and assurance when we know that a clinic is closing? Or is it really reverse causal? The health directors, when they decided which clinics to close, they didn't use a random process to select the clinics, right? They picked the clinics that they thought would be least impacted and the clients that they thought would be least impacted or that would make the least disruption for their region across all their counties. So is it really that we do a better job when we're closing a clinic, or that we close the clinics that we can most afford to close, and then when we reduce capacity at a clinic, it's a clinic that we don't want to close because it's providing services that we think would really be missed if it's closed? So is that why there's a bigger impact for reduced capacity than a clinic closing? Or is it a bit of both? And we feel strongly that it's probably a bit of both. But even if it is reverse causal, the implications for practice remain pretty much the same. Reducing services at clinics that serve a larger number of clients causes a substantial barrier to services, and case management and care coordination are still essential in these situations. And I will leave it at that.
Mike, thanks for your insights there. Nathan, any response to that?
I think Mike did a great job summing it up. Mike has been involved in this project, and he and I have worked together for a long time. So his insight from the practice side is certainly appreciated, and has really been instrumental in helping us kind of visualize the research moving forward. So, I think he's right on there, and I certainly appreciate his perspective as well.
Great. We have about 12 minutes for questions. If you all have any questions, please type them into the chat box on your Adobe Connect screen. We have one question from Ann Kelly. Ann's question, Nathan, is, did the health departments continue to provide education services as part of the clinic visits after the Medicaid payment for education services was cut, or were the education services eliminated due to the lack of payment by Medicaid?
I think I'll let Mike hop in and answer that one. My inclination is that they didn't stop providing those education services. I think that's just kind of part of routinely what they do as part of their family planning visits. I think they just weren't getting paid for it anymore.
Yeah, this is Mike. Nathan, you're exactly right. They did not stop providing those education services during the family planning visits because that's the standard of care that they provide for the Title X program. But they just weren't being reimbursed for that separately by Medicaid anymore.
Right. I kind of have a question somewhat related to access. You have both, Alana and Mike and Nathan, you all kind of brought up the access issue. So, obviously you've seen some association between the closing or the reduction in capacity and some negative health outcomes. Wondering if there's any way that, in your study, how did you look at that in relation to the availability of, let's say, these folks who were in these areas where there was reduction in services to go to private providers and get looked at? What specifically did you do to kind of examine that part of the issue?
Yeah, and I think just from a methodological perspective, in our models, we included changes in provider caseload, whether it be a private provider or FQHC. Yep. So we tried to make sure that in all of our models that we accounted for kind of the underlying distribution of what was happening over time. Now, that's not the same thing as looking at it specifically. That's just kind of statistical controls. But we definitely were cognizant of that, and that changes outside of the DHEC capacity could certainly be influential on that. But in the context of this study, we just kind of used them more for control variables, but we didn't really focus in specifically on those, at least not yet.
Yeah. You didn't notice any association between, like, say, the density of providers in an area and, kind of some of those other issues as well?
Not necessarily, no. And one thing I'll point out really quickly before we run out of time, this particular webinar is in the context of family planning and clinical service retraction. We've done some other research on similar issues, looking at EPSD&T and well-child visits. It's kind of a similar situation, except with EPSD&T, the DHEC got totally out of the business. And on your screen, I think you can download an issue brief that we've got about that particular research. So it's all kind of related. Like, this is kind of the research that we've done a lot in South Carolina. In that way, it was a little bit different. I mean, we saw some pretty definitive differences in what happened to service received amongst kids, particularly those who lived in rural and underserved areas. We saw some, for the most part, I mean, kids who lived in rural and underserved areas are much less likely to get those visits over time, whereas when the health department was doing them 15 years ago, they were more likely. So there's, I think that's part of the challenge of doing the kind of research that we're doing, is that, in the context of family planning and this, kind of targeted retraction, we see some impact, but it wasn't really anything that got us too excited. With EPSD&T, similar in concept, different study population, a little bit different environmental context, the impact was much more substantial. So I think that, it kind of alludes to the fact that we need to kind of understand that, what may be true in one population and one type of service may not be true in another.
Very good point. Any other questions? I have a question or a comment rather, from Don Middleton. Don has written that perhaps there was an excess capacity in the system, and reductions spurred implementation of the systems to promote greater efficiencies in systems and processes to maintain with reduced resources. Don suggests there is some evidence that many health systems, including health department systems, are structured in a manner that does not promote efficient allocation of staff's resources or promote efficient, effective systems of care. So I guess Don's suggestion is maybe these reductions were driven more by inefficiency and less by, let's say, just general some other influences. Any comments on that?
No, I would probably say that that's pretty accurate. I would agree with that.
Well, and this is Mike again, and I would say that there are absolutely inefficiencies that can be shored up, and that's something that we spent a lot of our resources at an agency level trying to do over the past couple of years. But while the inefficiencies might be more uniformly distributed, the counties with closings and with reduced capacity were not uniformly distributed across the state. So the fact that we see a difference by whether or not there was a closing or reduced capacity, or a closing and reduced capacity, suggests to me that it's more than just inefficiency everywhere in a state government operated system.
Very good point, Mike. And I think that raises the broader question of how would you even define efficiency in this specific case? I mean, because efficiency is not necessarily quality, so there are some very different constructs there. We've got time for a few more questions. Looks like Ann.
Hi, this is Ann Kelly. I'm a slow typer, so
no, go ahead, Ann. Jump in there.
Ask my question online. Based on those last comments about rurality, I wonder if you were able to look at variation in the outcomes based on the degree of rurality rather than, in addition to, the level of closing or reduced services?
Yeah, I think we included that in our models and looked at it, but I don't think that it was overly compelling in the context of this study.
And then I was thinking about the infection rates may take longer to show up than the amount of time that has elapsed since people receive fewer services at the population level.
Yeah, I agree. Yeah, I mean, I think the increasing STD rate that we saw in and of itself is another issue that needs to be addressed entirely, maybe.
Yeah, and would you be able to do any cost analysis or efficiency analysis alongside these other measures?
I think it would be possible. I think that it would. I don't know how the state health department would feel about an outside researcher coming in and look at some of their financials. So I think that it's possible. I think it could be done. I think it's. I think we could, but I don't know that there would be the political will necessarily for something like that. I don't know. I could be wrong. Mike can correct me if I'm wrong.
Well, and it might be, a different study that's multi-state, but there is a lot of interest in research on efficiency as at the same time looking at the outcome measures for public health services.
Yeah.
And I think you certainly made the case that we can't rely on the clinical services system to completely deliver the services needed, but there has to be the efficiency analysis as well to make that case in a lot of situations. So some thoughts for the future.
That's a great point, Ann. It looks like we've got no more questions. We're almost out of time. So, Nathan, Alana, and Michael, thank you very much for your commentary and your thoughtful insight. We appreciate it.
Thank you.
Our next Research in Progress webinar is next week, Thursday, January 22nd. The topic is using an evidence-based framework to identify improvement measures for the New York prevention agendas, promote mental health and prevent substance abuse, priority, by Chris Malon and Priti Irani from the Office of Public Health Practice, New York State Department of Health. So thanks for joining us today, and if you have any questions, feel free to contact Ann Kelly, our project manager, at ann.kelly@uky.edu.